Hey, welcome back. Chapter 19, Part B. This is the cardiovascular system. We are discussing Part 2, the blood vessels. Let's take a look at this particular picture showing us the cardiovascular anatomy and blood flow. It's actually a hemodynamic um, picture to pretty much like give us an idea of how the blood is flowing from the heart to the systemic circulation back to the heart, then from the heart again to the um, respiratory circuit, then back to the heart. We are not going to be discussing the coronary circuit. We are just going to look at the systemic as well as the pulmonary circuit. So, from the systemic circuit, from the different body parts, from the from the upper body parts, from the lower body parts, the blood is now going to be delivered into the vena cava. From the lower parts, mostly they are going to be getting into the inferior vena cava. Let me take a look. Let me look at my pointer. So my pointer, there you go. There you go. Hello, pointer. So, um, so from the top, from the superior part of your body, it blood is now going to be getting into the superior vena cava. So you have this is actually your superior vena cava. That's actually the superior vena cava, and it will, together with the inferior vena cava, the superior vena cava or the vena cava itself is going to deliver blood into the right atrium. The right atrium now will slowly, about 80% of the blood now is going to slowly trickle in to the ventricle. When the right atrium contracts, the rest of the 20% is going to be delivered into the right ventricle. The right ventricle now will start to expand and feel that it's actually filling with blood, and then eventually the um, after the atria contracts, the ventricles now will contract. The beginning of the ventricular contraction pretty much um, will close the tricuspid valve or this AV valve here. But then your pulmonary valve is still closed. And so a little bit more of a nudge and a little bit more of power coming from the ventricle, it will open, and soon after you offset the afterload or the pressure that is actually in the pulmonary trunk, then the pulmonary valve opens up. Pulmonary valve opens and delivers the blood into the lungs. In the lungs, the blood is going to be picking up all of the gas, the vital gas that we need, oxygen, and will pretty much also exhale carbon dioxide. So on the way back from the lungs, it goes back into the left side of the heart. It goes right through the pulmonary veins. You got your left pulmonary vein and your right pulmonary vein. They both, the two sets will enter into the left atrium. Left atrium now will allow the blood to fill the left ventricle, and it will fill it, and then when finally both atria contracts, then the rest of the 20% of the blood goes into the left ventricle. The left ventricle feels the pressure of the filling blood and eventually will contract. After it contracts, the mitral valve, here you call it the bicuspid or the mitral valve, will now close. And you feel that you need a little bit more power or nudge and a little bit more once the force of contraction overshoots the um, the the pressure inside the aorta, then your finally your aortic semilunar valve will open up. Usually it takes about 120 millimeters of mercury pressure to open up the aortic semilunar valve. And finally, the blood is going to be delivered into the um, into the big arteries, into the aorta. From the aorta, which is actually it's now going to be going to the distributing arteries, the muscular arteries, and will be distributed to the different parts of the body. And then the capillaries. In the capillaries, that's going to be um, an exchange between um, the blood that is actually flowing to supply oxygen to the capillaries and to pick up the waste also from the capillaries. Oxygen as well as supplying also food to the tissues. Then again, blood now is going to, this is actually deoxygenated or oxygen poor blood, is now going to be flowing back in systemically into the inferior and superior vena cava. So we just finished really the circulation in the heart that covers only the systemic circulation as well as the pulmonary circulation. The systemic circulation is the flow of blood in the heart that delivers blood to the different body parts. Okay, and it's actually oversimplified. And the pulmonary circulation, I just discussed also an oversimplified version because I only mentioned that from the uh, pulmonary trunk, it goes to the lungs and then back into the heart, into the left atrium via the pulmonary veins. Very simplified, but that's actually the simplified version of the hemodynamics. So now we're going to get into the physiological things that is happening inside the blood, the flow of blood. How is it affecting the blood vessels, or how is the blood vessels or the different character of different blood vessels affect the flow, the pressure, and the resistance or of the blood. So blood flow. Here's the first one. Blood flow is the volume of blood flowing through the vessels, the organs, or the entire circulation at a given period. It is measured in ml per minute. It is equivalent to the cardiac output for the entire vascular system. So blood flow is actually equal to the entire cardiac output for the vascular system, but not the heart, all right? This is actually cardiac output for the entire vascular system. And overall is relatively constant when at rest, but at any given moment, it varies at individual organ level based on the needs. When you are thinking, for instance, when you're thinking, your brain would need the blood because it would need the oxygen because it needs all of the ATP when you are thinking. When you are digesting, then there's vasodilation of the capillaries uh, that are sending blood into your gastrointestinal tract because you would need to digest. So if you are actually moving and doing some muscular activity and exercising, then most of your blood will actually be in your muscles. So the overall blood flow is actually relatively constant, but at any given moment, it can actually change depending on your movement. Blood pressure, on the other hand, is a force per unit area that is exerted on the wall of blood vessel by the blood itself. It is expressed in millimeters of mercury and is measured as a systemic arterial blood pressure in large arteries near the heart. The pressure gradient provides a driving force that keeps blood moving from an area of from a higher to or towards a low pressure area. And right here you have an example of a number 130 over 80, which is not really the standard normal blood pressure. The standard normal blood pressure is 120. The ideal is 120 over 80. But the top number refers to the systolic number, when the heart contracts. This is a pressure inside the ventricles when the heart is actually in systole. Now, the pressure in the artery is 80, or at the lower number here is a diastolic number. This is actually the pressure measured inside the arterial walls, the big arteries, when the heart is at rest or when the ventricles are in diastole. Resistance also refers to peripheral resistance, is the opposition to flow, a measurement of amount of friction the blood would encounter with vessel walls, generally in peripheral or systemic circulation. There are three important sources of resistance: blood viscosity, or the thickness of the blood, the total blood length, and blood diameter. Let's try to find out how these three sources of resistance would affect resistance itself. Blood viscosity. This is actually the first one. Blood viscosity is a thickness or the stickiness of the blood because of the formed elements and the plasma together. The general viscosity, pretty much, the less easily molecules are able to slide past each other. That's actually the general viscosity. An increased viscosity would equal to increased resistance, which means if you have too much red blood cells and you're going to have thick blood, then you will have greater resistance to flow, which is absolutely true in almost like any fluid that you would want to flow into a tube. Now, the total blood vessel length is actually the number of blood vessels that is actually found in the body. It becomes longer whenever we get bigger. We get bigger sideways or we get bigger taller, our blood vessel grows with it. So if you add more tissue and you're gaining weight, your body would need to vascularize that added weight or that added tissue that you are actually grew with. And so the longer the blood vessel, the greater the resistance that is encountered. That's why when we gain weight, and I'm telling you, blood pressure is actually like directly proportional to an increase in blood pressure is directly proportional to resistance. When there's actually increased resistance, your blood pressure rises also. So when you gain weight, the more you are prone to have hypertension. Then you have blood vessel diameter. Blood vessel diameter has the greatest influence on peripheral resistance. Now, frequent changes in vessel diameter would alter peripheral resistance. The viscosity and blood vessel length are, if the viscosity and blood vessel length are constant, the peripheral resistance would be affected by blood vessel diameter. The fluid close to walls move more slowly than in the middle of the tube, which is actually called the laminar flow. You have sort of like a free flowing and faster flowing middle stream, like in the middle of the vessel, which you call laminar flow. Now, the resistance varies inversely with a fourth power of vessel radius. If the radius increases, the resistance would decrease, which means if your lumen would increase, and if the blood vessel the blood vessel lumen would increase, then the resistance would decrease, and vice versa. And if the radius is double, the resistance drop to about 1/16 as much. So again, to continue the blood vessel diameter, the small diameter arterioles are major determinants of peripheral resistance. The radius changes in these blood vessels very frequently, most especially in the muscular arteries, in contrast to the larger arteries that do not change at all. So Abrupt changes in the vessel diameter or obstacles such as a plaque or deposition of plaque from atherosclerosis would dramatically increase resistance. So the laminar flow would be disrupted and would become turbulent. And the irregular flow that is actually the one that causes an increase in resistance. Think of this milkshake, and it's really very thick. And I know that you all probably have had the experience of drinking milkshake using straw. Which one do you think will allow the movement of the milkshake much faster and would allow you to enjoy it? You have the thick one, you have also the thinner straw. With me, because I like to taste my milkshake and I finish it really in a heartbeat. I like this thick straw, and I hate using that because it gives it gives my buccinator, and the buccinator is your sucking muscle right here. It pains my buccinator if I use this one. Peripheral resistance. Um, Pretty much blood flow is directly proportional to blood pressure gradient. Blood flow is directly proportional to blood pressure gradient. Now, a change in blood pressure, change in that would pretty much like affect blood flow dramatically. If the change in blood pressure would increase, blood flow speeds up. Blood flow is inversely proportional to peripheral resistance. So when the resistance is low, blood flow is high. When the resistance is high, blood flow is low. Systemic blood pressure. Systemic blood pressure is reliant on the pumping action of the heart, which pretty much is the one that generates the flow. The pressure results when the flow is opposed by resistance. So systemic pressure is highest in the aorta, right there. Systemic pressure is highest in the aorta, and pretty much it declines throughout the pathway, and the steepest drop pretty much occurs in the arterioles. You can see the steepest drop right there. The arterial blood pressure is determined by two factors. The first one is the compliance or distensibility of the walls of the artery, which is elasticity, and most especially the walls of the arteries that is closest to the heart, and the volume of blood that is pumped into them at any given time. The blood pressure near the heart is pulsating, just like what I told you, because it gets into the elastic arteries, and the elastic arteries will pulsate. It will expand when there's actually high pressure. It will recoil when there's less pressure. So the rise and fall of the artery is actually what we feel as the pulse. So we are now going to be discussing and getting into words that would pretty much like give us an idea on how to understand blood pressure, because we are going to um, do some interactive digital blood pressure um, determination using our PhysioX in the lab. So systolic pressure is a pressure. Systolic pressure, right here, you have the ventricles that are contracting. This is actually the pressure exerted in the aorta. When this is actually contracting, all the blood is actually like flowing with great pressure right through the aortic valve into the aorta. And that's actually the systolic pressure that is exerted in the aorta during the ventricular contraction. The left ventricle will pump blood into the aorta, imparting all of that energy that stretches the aorta. It averages about 120 millimeters of mercury in normal adults. The diastolic pressure, you can see that here, the heart, the ventricles are in diastole. It's actually the lowest level of aortic pressure when the heart is actually at rest. And the pressure inside the aorta, which is about 80, is what you call the diastolic pressure. The pulse pressure. The pulse pressure is the difference between the systolic and the diastolic pressure. So in the lab, you're going to have some determination of pulse pressure. So the only thing you're going to do will be to take the number of the systolic number and the diastolic number of your blood pressure, and pretty much like take the difference between them. Your systolic pressure minus the diastolic pressure. The pulse is actually the throbbing of arteries that are close to the skin, and this is because of the differences in pulse pressure, which can be felt in areas where, in all areas where the arteries are actually close to the skin. So this is how we calculate the mean arterial pressure. This is now a different one where we're done with the pulse and pulse pressure. Let's now go to another one, which is mean arterial pressure. It is the pressure that propels blood to the tissues. So you could just imagine the pressure that propels blood to the tissues. Wow, that must be important. Yeah, it is really very important. Pulse pressure pretty much phases out near the end of the arterial tree. And the flow of blood is non-pulsatile with a steady mean arterial pressure. A heart spends more time in diastole. So not just a simple average of diastole and systole. The mean arterial pressure, when you want to calculate for the mean uh, pressure within the artery, you're going to have to take the blood pressure. First of all, you're going to take the blood pressure. Then you're going to multiply the diastolic by 2, and then you add it to the systolic, and then divide them by 3. Granting that your diastolic here, you're given here, you have your diastolic pressure to be 70. You multiply the diastolic pressure by 2. You add the systolic pressure, which is 102, and you divide it by 3. And here you're going to get your mean arterial pressure to be 80.66 millimeters of mercury or 81 millimeters of mercury. So your mean arterial pressure really is very important. The mean arterial pressure needs to be at a particular level or special so that there's going to be good perfusion of blood in the tissues. If your mean arterial pressure is low, then there will be poor perfusion in the tissues. So for tissues to be fed and to be supplied with oxygen and nutrients that is needed, the mean arterial pressure needs to be like in a good level. So use what pretty much like would affect your mean arterial pressure. Well, first of all, your cardiac output needs to be increased. Your cardiac output needs to be increased. If your cardiac output is high, then you know that your mean arterial pressure is going to be high too. Your total peripheral resistance should be just about right, okay, so that your mean arterial pressure is going to be good. Now, at any point in time, you do not want, because your mean arterial pressure is actually a factor of the cardiac output and the peripheral resistance. You do not, at some point in time, you do not want drastic change in any of these parameters, or else your mean arterial pressure will actually suffer. So the arterial blood pressure pretty much uh, can be a source of clinical monitoring of circulatory efficiency. The vital signs are taken when you get to the doctor, the pulse and the blood pressure, along with the respiratory rate and body temperature. And then usually the nurse will take the pulse, they take the radial pulse, and sometimes your doctor will also take will feel some pressure points in areas where arteries are close to the body. But most of the time, the radial pulse is actually enough. If they cannot find the radial pulse, they usually will palpate your neck, okay, in some areas where you find the pulse. These are actually the pulse signs of the body. How is blood pressure measured? In today's age, blood pressure is still measured uh, by a sphygmomanometer. The sphygmomanometer is the tool that we have started using since I could remember, and up to now, still have the sphygmomanometer. But the sphygmomanometer a long time ago is actually this kind of sphygmomanometer, the one that you see in a picture. Now the sphygmomanometer, you do not need to be pumping air. The only thing you need, or you do not need anymore to be putting a stethoscope right there, but you just put your cuff right there. It's digital and it will have a reading. No sweat. You can actually have your blood pressure very easily. You're going to be, I hope you know how to do the blood pressure at home if you have a sphygmomanometer, or if you're working as a healthcare provider, then I'm pretty sure you're not going to have any problem. But I'm hoping that you can actually have the chance. If you go to directed study, you will have the chance to practice how to take blood pressure. Remember, when you go to directed study in Lakeland at the LTB building, for every hour that you spend in the lab doing hands-on, which is really very critical, that you are going to earn extra credit points. One extra credit point. We usually have five. Let me explain that. We have five practical exams, and in each practical exam, you need to really review so much. So if you go to Lakeland and you spend time in directed study, for every hour that you spend in um, in directed study sessions to review for a particular um, a particular practical exam, you're going to get 1 point for every hour that you spend here, that you spend there, up to 5 points. So I can give you up to 5 points extra credit in your practical exam. For every practical exam, if you go again in your next practical exam, you again have that um, 5 hours, or if even if it's only an hour, okay, 1 point is 1 point added to your thing. If without it, I'm not going to give any extra credit point. So the extra credit is actually very good. I cannot mandate you, I cannot push everybody because this is an online course. I cannot push everybody to go to um, go to Lakeland. So those who can and those who really will manage and will really do their best to find ways to go and study and do some hands-on tutoring sessions with directed study, I'm pretty sure you're going to uh, you won't really regret going because you're going to earn your extra credit point through that. So capillary blood pressure. There is actually pressure gradient inside the capillary, and most especially as you move from the arterial aspect going towards the venule aspect of the capillary. It ranges from 35 millimeters of mercury at the beginning of the capillary bed to about 17 millimeters of mercury at the end of the bed. Now, the low capillary pressure is desirable because high blood pressure can actually rupture the capillaries. They can rupture the very fragile single cell capillaries. Most capillaries are very permeable. You don't need really high pressure. So low pressure can already force a filtrate into the interstitial fluid. You don't need much pressure. Actually, um, what would drive it, what would drive the exchange between the capillary is not just necessarily pressure, it is also the concentration gradient of substances along the walls of the capillary. Now let's take a look at the venous pressure. The venous blood pretty much is dark red. It changes little during the cardiac cycle. Uh, the small pressure gradient of only about 15 millimeters of mercury pressure um, is is actually visible because when the vein is cut, this very low pressure would make the blood flow pretty much like it's only flowing out of the cut area. That's exactly how low that 15 millimeters of mercury pressure is, and that's the effect of that very low pressure. And your veins are peripheral. All veins are peripheral. The arteries are deep setted. So all veins, that are, most especially the if you get a cut, um, your blood is not going to spurt out. Whenever the blood spurts out, whenever you get a cut, you cut an artery. You did not cut a vein. So the venous blood pressure pretty much is very low, and uh, the veins will have difficulty going back to the heart, most especially the veins of your legs will have difficulty going back to your heart, most especially when you're constantly on your feet. However, veins have what you call valves. So whenever you move, whenever muscles will be contracting, they are actually like going to be pumping the blood inside the vein. And they will push the blood, and the blood will not go back because you have the valves that is actually going to prevent it from dropping down. If you have a valve that is defective, that's the time if this valve here is defective, then the blood will pull on the lower valve. That particular pulling of blood can damage this particular area. It can enlarge, and that's actually what you call a varicose vein. But for a normal flow, venous flow, the valves are actually helping. Muscular pump, the contraction of skeletal muscle, will milk the blood back towards the heart. It is actually what and we have also what we call the respiratory pump. The respiratory pump, which is the pressure changes during our breathing. It will move the blood back towards the heart by squeezing abdominal veins as thoracic veins will expand. Then your sympathetic vasoconstriction, under the sympathetic control, the smooth muscles will constrict, pushing the blood back towards the heart. So this is exactly the things that help the veins, the blood of the veins, to move back to the heart. So let's take again a look at how we regulate blood pressure. Okay, pretty much we maintain blood pressure. It requires the cooperation of the heart, the blood vessels, and the kidneys, and they're all supervised by the brain. Then you have the three main factors that regulate blood pressure. You have the cardiac output, the peripheral resistance, and the blood volume. Then you have the blood pressure that varies directly with cardiac output, peripheral resistance, and blood volume. So we have to remember in the regulation of blood pressure, the flow of blood is equal to the change in pressure over the resistance, which means that the flow of blood is directly proportional to the pressure inside the blood vessel, but inversely proportional to the resistance. We've taken this already. Cardiac output is directly proportional to the pressure, but is also inversely proportional to the resistance. So by substituting that, and then we rearrange it, then we can actually determine that the change in pressure is equal to the cardiac output times the resistance. It shows that the blood pressure is actually directly proportional to the cardiac output and the peripheral resistance. The changes in one variable are quickly compensated for by changes in other variables. Recall cardiac output in the heart, the real cardiac output. When we were talking about the cardiac output of the heart, is actually equal to the stroke volume times the heart rate. So if the mean arterial pressure is equal to the cardiac output times resistance, then the mean arterial pressure is also equal to the stroke volume times the heart rate times resistance. This means only one thing. Anything that increases the stroke volume, a heart rate, or the resistance will also increase the mean arterial pressure. Your stroke volume is affected by the end diastolic volume, and heart rate is maintained by the medullary centers in the brain, and resistance is affected mostly by vessel diameter. So let's take a look at the regulation of blood pressure, not mathematically, but let's take a look at the general factors that affects blood pressure. You have short-term regulation, which is neural controls, short-term regulation that is hormonal controls. Then we have the long-term regulation, which is renal controls. Let's take a look at all of them. Now, short-term regulation pretty much is when the cardiovascular center, uh, let me take a, I think I need to have, pause it. I will pause this. Thank you for bearing with me. I had to take a glass of water there. I've been talking too much. So let's go back to our short-term regulation, the neural controls. The neural controls operate via a reflex arc, and it involves cardiovascular center of the medulla right there in the medulla oblongata, and the baroreceptors and the chemoreceptors of along the aortic arch, and the higher brain centers. The cardiovascular center is made up of clusters of sympathetic neurons in the medulla. Okay, so pretty much it is made up of the cardio inhibitory as well as the cardio acceleratory center, and these and they are the ones that would either control inhibiting or accelerating the regulation of blood pressure. Then you have the vasomotor center. It sends impulses via the sympathetic efferents called the vasomotor fibers to the blood vessels. It can it can actually continuously moderate constriction, vasoconstriction, which is called the vasomotor tone. So um, pretty much the cardiovascular center receives input from the baroreceptors, and chemoreceptors, and they are sent to the higher brain centers. The short-term baroreceptor reflexes, or the pressure receptor reflex, right there, that you find them in the aortic arch, located in the carotid sinuses and the aortic arch, and the walls of the large intestine as well, and the large arteries of the neck and the thorax, um, would control blood pressure. Now, if the mean arterial pressure is high, the increased blood pressure will stimulate the baroreceptors to increase input to the vasomotor center. If the mean arterial pressure is high, it will inhibit the vasomotor and cardioacceleratory nerves. If the mean arterial pressure is high, it stimulates the cardioinhibitory center, and these results in decreased blood pressure. Now, if mean arterial pressure is low, it is actually low. So this is really dangerous. I hope it's not dangerously low, but if it is low, there's going to be reflex vasoconstriction that is going to be initiated that will increase cardiac output and blood pressure. And you know what's going to happen if cardiac output is increased and blood pressure is increased, then eventually your mean arterial pressure is also going to be increased. A decrease in mean arterial pressure, a substantial decrease, is dangerous because a good amount of mean arterial pressure is necessary to move the blood or the things that we have to distribute in the tissues through the blood. If there's not enough pressure, then the substances that are needed by the tissues may not be getting to the tissues. For instance, upon standing, when you stand up really quickly, your blood pressure falls. It will trigger your carotid sinus reflex, the baroreceptors that monitor the blood pressure to ensure enough blood goes to the brain. The aortic reflex maintains blood pressure in the systemic circuit. The baroreceptors are ineffective if altered blood pressure is sustained. It becomes adapted rather to hypertension, so it's not triggered by elevated blood pressure. So this is actually your baroreceptor reflex that help maintain blood pressure homeostasis. Pretty much our stimulus here is that we have increased blood pressure. The arterial blood pressure rises above the normal range, and it is felt now by the baroreceptor reflex. And pretty much what's going to happen here is that there's actually now an imbalance. And on the other side, the stimulus here is actually the blood pressure, and the arterial pressure falls below the normal range. And what's going to happen next is on its side, the baroreceptors right there in the carotid sinuses in the aortic arch are stimulated, okay? And over on this side where the blood pressure, arterial blood pressure has gone down, the baroreceptors in the carotid sinuses and aortic arch are inhibited. On its side here where the blood pressure is going up, the impulses from the baroreceptors, from these baroreceptors, will stimulate the cardioinhibitory center and inhibit the cardioacceleratory center and inhibit the vasomotor center. That will cause, eventually the result will be vasoconstriction. You can see this blood vessel to be vasoconstricting. On this side here, when the blood pressure drops, the impulses is actually received from the baroreceptor, from this baroreceptor. It will activate the cardioacceleratory center and inhibit the cardioinhibitory center and stimulate the vasomotor center. Eventually, the effect is actually constriction. So, finally, on this side here, there's going to be like the decreased sympathetic impulses to the heart, which will cause a decrease in the heart rate. it will decrease the contractility, and it will decrease the cardiac output. Eventually, the rate of vasomotor impulses would allow vasodilation, causing the uh, the blood arterial pressure to go down, because the original stimulus was that the blood pressure was going up. So all of these things that happen here pretty much has now reversed that particular original stimulus and brings the blood pressure back to normal. In the other part, when the stimulus is actually a decrease in blood pressure, all of this information coming from the baroreceptor was received. It caused the a general vasoconstriction of your arteries, arterial wall, and eventually the result will be um, a generalized um, a generalized increase in blood pressure to um, augment or reverse the original stimulus. So now let's take a look at the neural controls, the short-term regulation neural controls um, of the blood pressure. You have chemoreceptor reflexes. You have chemoreceptor reflexes. The aortic arch, you can see the aortic arch right here, and large arteries of the neck would pretty much has chemoreceptors, and they are the ones that would react to changes in the chemical components of the blood. The aortic arch and large arteries of the neck detect a change in the carbon dioxide or a drop in the pH, or pretty much the oxygen levels of the blood, and they cause the increased blood pressure by signaling the cardio accelerator center to increase cardiac output, and signaling the vasomotor center to increase vasoconstriction. Here's now the short-term regulation, which is actually the neural control. First of all, this is actually the influence already of the higher brain center, which is actually the medulla oblongata, the reflexes that regulate blood pressure that is found in the medulla. Uh, the hypothalamus and the cerebral cortex can also modify arterial pressure via relays to the medulla oblongata. The hypothalamus would increase blood pressure during stress. The hypothalamus would mediate redistribution of blood flow during exercise and changes in body temperature. And all this will be affecting your medulla oblongata, the higher brain center. So the baroreceptors in the carotid sinuses, right there, you start again, the stimulus is actually coming from the baroreceptors in the carotid sinuses and the aortic sinuses. These are the ones that monitor the blood pressure. Sensory nerves will pretty much like conduct an action potential to the cardioregulatory centers and the vasomotor center in the medulla oblongata. Increased parasympathetic stimulation of the heart will result and is actually going to be delivered via the vagus nerve. Increased sympathetic stimulation of the heart increases the heart rate and the stroke volume, and increased sympathetic stimulation of blood vessel will also be affected. It will cause vasoconstriction. And here are the effects of selected hormones on the blood pressure. I put it in the diagram. It's actually, you're going to be looking at this when we get also into the endocrine system and also when we get into the kidneys. So this is not going to be the first time or the last time um, that you're going to encounter um, hormones that affect blood pressure. You are going to encounter them again when we get to the kidneys and the endocrine system. But it is here, and when it is here, Professor Queen needs to address it, right? So these are now the direct and indirect mechanism of renal control of blood pressure. This is supposed to be the control of blood pressure by the kidneys. You have two mechanisms. The first one is the direct renal mechanism, and the second one is the indirect mechanism. You call this the renin-angiotensin aldosterone system. Wow, that is very long, right? But the reason why it's very long is because you have this three different substances that are involved in the renal mechanism, which is the renin, the angiotensin, and the aldosterone. You're still missing one of them. You have angiotensin 1 and angiotensin 2. But we're going to get through them when we get into this. So the direct one, oh, the direct one. So pretty much, guys, the baroreceptors would quickly adapt uh, to chronic signs or of high or low blood pressure. So they are ineffective for long-term regulation, the baroreceptors. Long-term mechanism would control blood pressure by altering blood volume via the kidneys. And so it is the kidneys really that regulate arterial blood pressure by direct renal mechanism. This is your pathway to your direct renal mechanism. And there's also another pathway, which is your indirect mechanism. And this is actually your indirect mechanism right through this, all of this, which is called the renin-angiotensin-aldosterone system. The direct renal mechanism, let's go back to this part here, alters the blood volume independently of hormones. An increased blood pressure or blood volume will cause the elimination of more urine, thus reducing blood pressure. A decreased blood pressure or blood volume would cause the kidneys to conserve water and blood pressure rises. So the direct mechanism is actually driven by an increase in mean arterial pressure, which will okay, we start from the top. A decrease in arterial pressure, which will be affecting the filtration in the kidneys. It will decrease the filtration in the kidneys. Then it will also decrease urine formation. And when it decreases urine formation, it increases blood volume because you're not going to urinate. And that's going to increase the mean arterial pressure. So you reverse that, and that's going to decrease the mean arterial pressure. Meanwhile, in the indirect mechanism, in the same stimulus, a decrease in arterial pressure would inhibit the baroreceptors. And when the baroreceptors are inhibited, it will increase the nervous system activity. And once the sympathetic nervous system activity is increased, it will stimulate the release of renin from the kidneys. The renin is now going to stimulate the conversion of angiotensinogen into angiotensin 1. Now, with the help of angiotensin converting enzyme, and this ACE or angiotensin converting enzyme is found in the lungs. So this angiotensin converting enzyme will now be released from the lungs. It's now going to help in the conversion of angiotensin 1 into angiotensin 2. So once angiotensin 2 is around, then this angiotensin 2 can affect secretions of the adrenal cortex. Pretty much it's going to stimulate the adrenal cortex to secrete aldosterone. And aldosterone increases the reabsorption of sodium by the kidneys. So wherever salt goes, water goes with it. So you are reabsorbing water here. Okay. Angiotensin 2 also would stimulate the antidiuretic hormone, the release of antidiuretic hormone by the posterior pituitary gland. And the antidiuretic hormone will increase water reabsorption by the kidneys. So you're actually reabsorbing water here. All right. So pretty much your original stimulus is actually a decrease in arterial pressure. Okay. So now you're seeing that it is now reversing. All of this is now reversing that particular original stimulus. By reabsorbing water, you are now actually uh, um, elevating blood pressure. So an increase in thirst is actually stimulated by angiotensin 2 via the hypothalamus, and that will increase water intake. Vasoconstriction and total peripheral will increase total peripheral resistance and will increase mean arterial pressure. All of this, the net effect will be to increase blood volume and to increase mean arterial pressure. So, the goal of blood pressure is to keep the blood pressure high enough to provide adequate tissue perfusion, but not so high that blood vessels are going to be damaged. For example, if blood pressure to the brain is too low, perfusion is inadequate and the person would lose consciousness. If blood pressure to the brain is too high, a person would have stroke. So pretty much the goal of blood pressure really is to make sure that the blood pressure is just right for tissue perfusion to occur. If it is too low, then tissue perfusion will also be reduced. If it is too high, then it might damage the blood vessel. Let's take a look at homeostatic imbalances in blood pressure. The first one is actually hypertension. Since we are already there, it is the sustained elevated arterial pressure, which is about 140 over 90 millimeters of mercury pressure. This is already known as the high blood pressure. It is a condition where the force of your blood against your artery walls is consistently too high. It is called the silent killer because it usually doesn't cause noticeable symptom until there's already serious damage that has occurred. If left untreated, hypertension can lead to a heart attack or a stroke or a kidney disease and other health problems. Prehypertension. These are actually transient blood pressure occurring during changes in posture, physical exertion, emotional upset, fever, and prehypertension is actually a factor of age, sex, weight, race, mood, posture. Also may be the cause of variations in blood pressure. Primary hypertension. Primary hypertension, pretty much 90% of hypertensive conditions has no underlying cause that you can identify. Uh, the risk factors of primary hypertension include heredity, diet, obesity, age, diabetes, stress, smoking. No cure. There's actually no cure, but primary hypertension can be controlled. Just restrict salt, fat, cholesterol intake, and increase your exercise, lose weight, stop smoking, and of course, the use of antihypertensive drug. Oh, this really is affecting me because I know I have high blood pressure. Crap. Sorry. Uh, I did this already. This already. Secondary hypertension. We're supposed to get into secondary hypertension. Secondary hypertension is less common. I did the primary, the secondary hypertension is less common. It is due to unidentifiable disorders, including obstructions of renal arteries, kidney disease, and endocrine disorders such as hyperthyroidism, Cushing syndrome, and the treatment of secondary hypertension is focused on correcting the underlying causes. Hypotension. I used to have hypotension when I was young, but now uh, my blood pressure is really uh, high. Hypotension is low blood pressure of 90 over 60, which is really good. Those were the days. Usually, it's not a concern having low blood pressure unless it causes inadequate flow to the tissues. It is often associated with long life and lack of cardiovascular illness. Orthostatic hypotension is the temporary low blood pressure and dizziness when suddenly rising from a sitting or reclining position. But chronic hypotension is a hint of poor nutrition and is a warning sign for Addison's disease or hypothyroidism. Acute hypotension is an important sign of circulatory shock. This is something that should be avoided. Circulatory shock is a condition where blood vessels would inadequately fill and cannot circulate blood normally, and this inadequate blood flow cannot meet tissue demands. Hypovolemic shock results from large scale blood loss. Vascular shock results from extreme vasodilation and decreased peripheral resistance. And then cardiogenic shock results when inefficient heart cannot sustain adequate circulation. And I think we're just about in our end. And I will see you in our next chapter.